And prior to this, I was with Maine Medical Partners, first in Portland, and then we were in Scarborough from 2015 until 2021. And I also served the communities of Bridgeton and Biddeford during that time. And let's see, so at Maine Medical Partners, I did everything, you name it. You guys, I'm sure, are aware, Maine is a very underserved state, in particular, well, providers all around, but specialists. And so previously there, I did anything from anything ear, nose, and throat you can think of: cancers, sinus problems, ear problems, thyroid, neck, airway, breathing, tracheostomy tubes, children, adults, everybody. And took call. When we would take call, we would take it for the whole state. And ultimately, I decided that that pace of life was a little bit too fast, unsustainable. I have 3 young kids, 3 young boys, and I really, really love patient care. I like unrushed visits. And I went into ENT because I love the senses. I talk to patients about this pretty much daily, and I'm sure you can probably relate. You smell something and it reminds you of a memory from way back. You hear a song, it reminds you. If you can't use your voice, that affects your daily interactions. Smell, as we all know with COVID, that sort of brought smell loss to the forefront. And so with taking a step back from Maine Medical Partners, I said I really want to take care of patients, but I want to do it in a way that focuses on the patient-doctor relationship. People can get in quickly. They can have longer visits as needed. And a lot of what we do is in-office procedures, and people come from all over. They take time off from work. They, had to wait 4 or 5 months even to get in. And then when you were able to offer them something in the clinic, and then we had to schedule again 3 months out because of insurance approval or time of, length of visit, you name it. I always felt that was really frustrating. And as a patient, which I think probably all of us have been patients in the state of Maine, I'm sure it's the same in New Hampshire, just, waiting to hear back from your doctor, waiting 2 weeks to get a referral through, all of those frustrations. I thought to myself, there's got to be a way to do this where we can make it simpler and focus back on the patient-doctor relationship. I also really enjoy education. I love having anatomy models, showing people, explaining to them what I consider very cool anatomy: the nose, the throat, the ears. And I also believe in not everybody, just because we have a bunch of medications and also surgeries, that doesn't fit every person. And so I really enjoy explaining to people their anatomy, what's going on. For example, if they snore, what part of their nose is due to swelling, what part due to anatomy, and then treatment options anywhere from the most simple, like saltwater spray, as you mentioned, which is one of my favorite things in the world, is the saltwater mist that you can buy at the store, to all the way to surgical treatment options, and let them feel informed, have time for questions, and then, when they're ready to reach back out, should they want to think about it, make it so that it's not a 3-week, 4-person voicemail rigmarole to get back in touch with their doctor. So I opened up my clinic, Pierce MD, and I'm currently out of network, so I'm able to see anybody with any insurance plan or not, and I'm able to offer them really transparent pricing, upfront explanation of what we'll do. I book my visits for about an hour, and I do have exciting news is I'm actually moving into a bigger space right across the hallway from where I am. Bad news is that pipes burst in there this weekend. So the move-in date of the 18th might get pushed back. But I'm going to be with more space, and I just hired a medical assistant. I'll be able to do a lot of in-office nasal procedures. Right now I do ear procedures, earwax, all kinds of things. But there's so many things that are actually not available in the state of Maine in office. Balloon sinus surgery, turbinate reduction, even in-office septoplasty, which is straightening the septum, and a couple different procedures for chronic runny nose. So I'm really excited this year to be able to offer those and spread the word. And I really believe in collaboration. So Nick and I got in touch through this Maine Airway collaborative, the ear, nose, throat, dental, jaw, tongue, base of tongue, all of this affects our breathing, our airway. just because we are all in different specialties. I say the human body, didn't read that textbook. It doesn't care. It's all connected. And so I've loved getting to know everybody in this airway collaborative where we see patients, they come to us or land at us from different sources. And currently, and Dr. Roy can definitely speak to this, you have somebody, they need something. For example, I might have somebody with something dental that I know is going on, that's the cause of their ear ringing, the cause of that's X, Y, and Z. But to find a dentist who you can get them in quickly with and who gets it, if you will, and is willing to see the big picture, think outside the box, and work as a team to solve the problem, that's not always easy. And vice versa with ENTs in Maine. I know that's been a thing with the dentists. Difficult to get in, get your patient in with an ENT who also wants to be collaborative. And I guess I should say has the time and bandwidth to be collaborative, because that's often the rate limiting step, knowing, since I know all the ENTs in the state, I know the pressure that they're forced to work under. Sorry, let me turn this up. So anyway, that's how we got in touch. And as soon as Dr. Roy and I started talking, he's like, I have these patients I think would be great for you. And I was thinking, gosh, I have patients who I've been looking for a dentist who, thinks the way you do. So we were really excited to get in touch that way. And we've been working with Heidi and myofascial functional release for snoring. So those are all, I guess that's the background on me. I see kids, I see adults, I see old, young, healthy. An area that I really love working on is the nose. And I get super excited every day talking to people about their boogers and the importance of what the nose does, that it tells our brain that we're breathing, and it helps keep our parasympathetic, which is the calm part of our nervous system, helps to keep it calm. And we live in Maine where there's lots of allergens. Things are either always blooming or always dying. Allergies are a huge thing. So I love being able to combine all of that. And, any like-minded group that I'm able to communicate with, share patients with, and feel like we have a team, I get super excited about that, which is why I'm so excited that Dr. Nick asked me to join.
Yeah. Well, thank you for coming, Liz. And we also have Dr. Dave Jacobson here, who works with Heidi, excuse me, where ultimately we were connected.
Yes.
I can't help but thank the universe, and I've shared this with you, to use a, somewhat important topic, which is collaboration. And you're right. I think the bandwidth of the medical and dental communities is narrowing as the external pressures start to increase, whatever those external pressures are. Collaboration seems to be less and less important. So I'm excited. I know you're excited, and there's several people on this call that are excited to have an ENT that we can refer to. I have spent, when I say 7 years, not every day within the past 7 years, but for 7 years trying to find an ENT that is willing to talk. And the moment I met you, I knew you were the right person, and it happened at the right time. As we're starting to do more and more dental sleep medicine in our practice, we kind of feel handcuffed because we can't necessarily pass off certain procedures that need to be done that augment and facilitate our treatment. Nasal breathing being probably the top of that list. So what I'd like to do, I'm going to go ahead and share my screen, and I have some slides, and anywhere where you want to interject, add comments that you think is of value for this audience. I put these slides together to try to shed some light on the things that we see in patients' mouths that I think you have some insight on. And if you have any questions on the flip side of it too, that would be perfect. All right, so let me share my screen. Everybody loves this moment where I try to figure out technology. All right. Chad, we good?
All good.
All right. Chad's my screen man. All right, so the topic of tonight, an evening with an otolaryngologist, an ENT. So exploring the physical intersections between dentistry and medicine. In a nutshell, the space that we have are not far away from each other. We're working on the teeth, which come all the way over here, and just north of us we have the nasal cavity, obviously the pharyngeal space, so on and so forth. So there's a lot of crossover with certain conditions. We know this. But there tends to be a very hard line in the sand. We refer to the ENT, we may not have a relationship. We might not be getting the patient the best care because we're not necessarily speaking the same language that the ENTs are. And today is hopefully a journey towards better understanding so that we can collaborate with our colleagues better. But this world has a lot, at least from a dental perspective, has a lot of subject matter that is rather overwhelming. Sleep apnea, tongue thrust, tongue ties, the list goes on and on. So a lot of general dentists might get overwhelmed and not dive down this arena, but the ADA was pretty clear that dentists have to be very astute at maybe not treating sleep apnea or sleep apnea, but screening for sleep apnea. That was a position statement back in 2017 by the ADA, and they said you basically have to look for the signs and symptoms of sleep apnea. Well, what do you do when you see this? You need somebody to refer to, whether it's an ENT or a sleep center. We got to have some sort of outlet. Not ignoring the problem isn't necessarily acceptable. Well, there's a lot of anatomy here, and Liz, you had shared that you love the anatomy side of things, and I think it's important that dentists at least have a basic understanding of what's happening just outside our area of focus. Obviously, the teeth and the lips and the tongue, that's where we spend most of our time, but really knowing what's back here. Most dentists, I'll even admit that I have a pretty weak understanding of the anatomy back here, but understanding what goes on over here too. And a simple understanding of the nasal cavity is relevant because how we nasal breathe impacts bruxism. And I hope to talk a little bit about that. And I love how you brought up the parasympathetic conversation, because there's specialized tissue in here that produces nitric oxide, which activates the parasympathetic activity, which has been shown to be connected to bruxism. So understanding why it's important to nasal breathe is important to treat our patients with bruxism. Long gone are the days that we just throw a piece of plastic in there and just hope that the patient's going to get better. We have better ways, but we have to include our colleagues to make sure that they're taking care of the patients, because not all of the ENT community necessarily looks at these problems the same way. If we find an ENT that believes in the connection between good nasal breathing and central bruxism, then we're going to help our patients better. So it's almost, and this is why I've been looking so hard to try to find somebody like you, Liz. I didn't want to refer to any ENT, because a lot of times what would happen is I'd refer and nothing would happen. And I'm like, but I know there's a connection there, so you have to speak the same language, and the more conversations that we can have, the more language that we can create together so we have a solid understanding. This is just a basic anatomy slide. I don't know if you want to comment on this. You deal with this kind of area up here, obviously the nose, the throat, and the ears, which I think most of our conversation today will deal with kind of this slide here.
Yes, absolutely. And the anatomy in there, the first thing I would show people is sort of a picture like that of a 3D model that I show them, that the nose does not go up. That's a dead end. That's just cartilage and then bone. It goes back. And as you can see there, it's about 10 centimeters in the adult head, skull. It goes up about 8. And then there's tons of surface area. So there's a lot that happens in there. And just even sort of telling people that how much space there is in their nose and how much airflow matters. It's just amazing. People just, they get it. And a couple things that you mentioned, I see so many people for symptoms that the first glance might say, has nothing to do with the teeth. It has nothing to do with the jaw or the tongue. Sinus headaches. 80% of sinus headaches are actually, if you scanned people right then, there's no sinus problems. Their sinuses are not inflamed. They're not blocked. They don't have pus in them. It's musculoskeletal. There's different causes. But if you're clenching all night long and your jaw muscles are tight, your masseter, and then you get to your temporalis, all of that is tight. That can be a cause of headaches. We see people for ear ringing, which can be many things, but a lot of times it's the jaw is tight, the muscles are tight. So all of this overlaps. And just like you said, you try to send someone to an ENT because they have a problem, and then you never hear anything back. I've experienced that on the opposite side with, we know they have jaw clenching, we know their bites off, all these different things, and you send them off, and maybe you hear back, but maybe not. And they say, my dentist says I'm fine. You're like, so the anatomy, just the complexity and the overlap of it can't be overstated. And then we even have people who have tonsils, big tonsils, which we think now has to do with mouth breathing, and they can get overgrowth of anaerobic bacteria in their tonsils because their mouth is open, because they can't breathe through their nose, and they thrust their tongue, and then they get sores in the tip of their tongue, and they come to see us because they have burning tongue syndrome. So I could just go on and on about all the overlaps, but it's intrinsically all connected. And the nose it has 20, there's more, I believe, but 20 different jobs if you had to sort of write down things that it does to help regulate. And we are meant to breathe through our nose, both for purification of our lungs. The air that goes through our nose, by the time it gets to our lungs, the ideal situation is it's filtered, it's warmed, and it's humidified. So we are meant to breathe that way.
Yeah.
And then, as we've talked about, the bruxism is, I think everybody, at least in the ENT world, and I think someone in the dentist work, sort of dentistry world, it came up as like, oh, the rates are increasing because of COVID. I think it's always been, everybody living through a pandemic. I don't know if you've noticed the rates have increased, but I think it's more, part of it is we're just aware, just like we're more aware of sleep apnea.
Right. Yeah, there's definitely a lot of connections there. And, a lot of the things you alluded to, we have some slides on, but I like coming back to this slide to have a conversation with myself about what the relevancy is of all of these areas. Here's a frontal view to show, we see the sinuses on our x-rays all the time, the maxillary sinuses, and they're connected through the infundibulum here, or the osteomeatal complex, which is essentially just the draining of the sinus. And we look at this a lot when we're doing sinus surgery. So we're putting implants down here. We want to make sure the sinus is draining. So all of this is related. Here's another image here, and I threw this one in here in great part because I want to have a conversation about the fact that the palate size is related to the real estate of the airflow in the nasal cavity. So a very simple statement is the roof of the mouth is the floor of the sinus, the nasal sinus. And this is a very simplified diagram. This is a two-dimensional representation of a very, very three-dimensional situation. But the point is that we need airflow, or we need space here for proper airflow. And if we don't have proper craniofacial development at a young age, we're going to have nasal obstructions. And a lot of what Liz does is she tries to help patients increase their nasal flow through, I think you said it earlier on, one, finding out, is it swelling of the mucosa, or is it an anatomical problem where there's not enough space, or is it both? Many times it's probably both. But the reality is that we want to make sure that when we have the opportunity in younger kids to get this palate to expand, we really have to. And I want to come to that. I'm going to come back to this slide here. This is more of a question I have for Liz. I wanted people to benefit from her answer. But I wanted to tell you what, let's go back here. I have some slides on the craniofacial development, so we'll table that for now. But coming to this slide, sorry, my internet is a little laggy. So we look at CAT scans a lot. We do a lot of surgeries. This was actually a sinus bump that I had done. This patient that was there, they had a fully pneumatized sinus, so they had no bone to place the implant in. The implants eventually went in. This was a very, very deficient maxilla. This is the roof of the mouth, and there's his maxillary tuberosity, where normally it's down here. So long story short, I was placing an implant here, and I always want to look what's nearby. So I often look at this slice here on the CAT scan. Forget the sinus surgery, but when I look at this, how do I know whether or not the patient should go see you based upon the size of the turbinates in relation to the surrounding tissue? So is this very constricted? Is this a patient that should get referred to you?
That is very constricted, yes. And when we think about airflow going in, I know you know this, but anybody looking at it, we think of like your face, if you look at this and you were to blow at that, your air would have to get into only where that black tissue is, which is a very thin amount. It would have to get around that large gray swollen tissue. And the opposite side, the patient's, assuming this is on the right side, there's a little bit more room. That's a little bit more reasonable. But that patient's left side is very, very obstructed. And I also see that the bone, the inferior turbinate bone, which is in the middle of the gray there, kind of right there, typically you can't even see that bone. Sometimes you can see a little slice of it, but I can tell there it's a little bit thickened, a little bit hyperostosis, which can be from long-term swelling, which is also something we look at. So yes, that kind of person. So the thing is, if this was done when someone had a cold, I don't know, they had just been crying for a week, they'd been supine for a week, like those things can make your nose really swollen. But assuming this is somebody's baseline, there's ways to improve that person's nasal airflow quite a bit.
Sure. Can you describe, so here's the bone of the
Mm-hmm.
turbinate. This is the
Yep.
soft tissue. So what is the soft tissue? What's its function? What's its purpose?
Yeah, so the soft tissue it has a large amount of blood flow to it, and these are our turbinates, which are short for turbines. And if you shined a light in someone's nose or you stuck your finger in, you would hit something boggy or you would see something pink and boggy. And that tissue has a job. The surface of it has sensors that tell our brain we are breathing through our nose, which is very important to people who have obstruction of their nose, aren't getting as much sensation or reassurance to their brain of we have airflow, oxygen is good, and those people can actually have low levels of anxiety that they can't quite explain. But that tissue senses air. It also filters, warms, and humidifies air so that by the time the air gets all the way to our lungs, it is clean, it's warm, and free of allergens. That tissue also makes mucus, which is supposed to be a very thin, I think of it almost like a thin gel layer. Pollen, dust, viruses, bacteria, particulate matter, you name it, anything in the air is supposed to get enveloped into this layer of mucus and then carried down into our stomach where the stomach acid kills it. So that tissue is very important because it's helping do all those things for the lungs and in theory protect our lungs from viruses and allergens. However, if that tissue is always swollen, if this is its baseline, there's very little airflow. And that tissue also swells up. So if you've ever listened to you call someone in the middle of the night and you can tell from their voice they've been sleeping, that's because their turbinates have swollen up a little bit. They have that slightly congested voice. The tissue has a lot of blood flow. We also call it erectile tissue, meaning a lot of blood can go to it quickly. If you cry, if you have a cold, if you are laying down, or if you have allergens, and it's supposed to kind of come and go and do that as needed, stay swollen and then shrink down. But if it stays swollen at a chronic level, like that person's, that's where we get into, okay, is it allergies, or has the tissue sort of decided it wants to stay that thick for reasons we don't quite know yet, but we think it has to do with various factors. And that is where we're able to physically shrink that tissue with a procedure, still preserving the function in the outside of it, so that the outside does its job, but we literally shrink it in.
Yeah, and that I had nasal surgery done last year, in great part because I've struggled with sleep apnea my whole life. Even when I was thin, young adolescent male with, I was relatively active, and I'd go on camping trips, and I was always the person that snored the loudest. And one might argue is because I was nasally obstructed. Can you talk a little bit about the more conventional, the layman term is rotor rooting, where the I'm sure you hear that quite often. Essentially, was the original classical technique just to cut this off, and what happens with that technique that is unfortunate, and what are the more modern techniques?
Yes, great question. So back in the 90s, early 90s, late 80s, which wasn't that long ago, when everybody said, oh, this is what's causing all the congestion in the nose. And some ENT surgeons said, well, let's just take them out. Think of all the room we'll make if we just take those turbinates out. So you can imagine if that gray circle got taken out, there'd be a whole lot of black, a lot of airflow. They took those out of people's noses, turbinate resection, completely removing. And those patients immediately came back and said, I can't breathe. They would say, they were panicked, they were anxious, they said, I can't breathe through my nose. People looked in their nose post-operatively and they said, sure you can. You have lots of room in there. You could drive a truck. And those patients said, nope, I can't breathe. And that's where they realized that the sensors that tell your brain all is good, we're getting oxygen, are on the turbinates. So that's called empty nose syndrome. And that is something we do not do anymore. Every now and then we have patients who have that just because they've had their turbinates reduced too many times, perhaps with too much scar tissue or too aggressive a removal. Or every now and then we have patients who have cancer for different in their sinuses, and we have to take out their turbinates to get in there. But we definitely do not remove those anymore. So that was that was not a great time in the history of ENT surgery.
So now you do something that's more akin to like liposuction, where you remove the inner tissue, keeping the outer surface tissue because it has the functionality that you described intact.
Exactly.
Yeah.
Yes, and so there's two main ways to do that, and both of these can be done in the operating room asleep or in the clinic if you give people a little anxiolytic, numb them up, take the time, kind of walk them through it. People do really well. Interesting little note is during anesthesia, the general anesthesia for surgery, sinus surgery, nose surgery, the gas actually causes tissue to, what's the word I'm looking for, relax a little bit. And it actually can increase bleeding, sort of a diffuse bleeding. So if you do nasal surgery actually with somebody awake in the clinic, you have less blood loss.
Right.
So just of note, which seems almost counterintuitive because you don't want someone awake bleeding on the back of their throat. But so now we do some total IV anesthesia, which is decreased blood flow. But if you do procedures like these in the clinic, it's surprisingly small amounts of blood. And if you've ever had a nosebleed, you know the nose can bleed because there's a lot of blood flow. But yeah, so what we do now is there's two ways to do it. One is they both involve exactly what you described. It's taking that swollen, thick tissue and respecting that the bone's on the inside and shrinking it from the inside, sort of from the point of the bone, circumferentially to preserve the outside. And there's radio frequency ablation, which is literally like a radio frequency that it's like down a needle and you can see it shrink in front of you. And then the way that I prefer doing that is the data shows much more long lasting is literally rotorotary. It's a tiny liposuction. It's this skinny little instrument, and then it has a tiny hole in the end with this little, literally, I guess it's a rotor. It's just it sort of grasps the tissue, and on suction, and you stick it down the length of the turbinate, and it shrinks the tissue, and you turn it so you get all of it. And just watching it, it's amazing. Literally, the whole thing will shrink, and then you're done with the procedure. And then what happens is those next 6 weeks, the scar tissue continues to pull it in, and people almost always immediately notice an improvement of airflow, but it actually continues to get better for 6 more weeks. And then the position that it shrinks down to is where it will essentially stay.
Great. With the ultimate goal of increasing the airflow. So this, you could think of this as like a post-op, although I hope post-operatively there would be maybe more space, but it's in essence just increasing the airflow that's there so that we can have patients breathe better. And when they breathe better, we see things dentally that are very important.
Yes.
I'll come back to this slide here. There's a series of slides that I wanted to talk about, and it's this here. So this talks about the different moments in a dentist's journey where we have an opportunity to help patients breathe better. So treatment mode, treatment types, and specific resources. So we have prevention modalities, things like phase 1 orthodontics, myofunctional therapy, chewing hard foods at a young age, which fosters craniofacial development, proper nasal breathing. ARC tools are chew tools for kids that maybe don't have hard foods in their diet. And then the resources, and I put this slide here, this comes from a different lecture that I've done. We need a great ENT to deal with some of this. These are the young children, so 0 to 6 maybe, and then early treatment modalities. And I put the word treatment here because we're actually treating the patients. Phase 2 orthodontics, palate expansion surgery, so on and so forth. Again, you need a great airway-driven ENT to have conversations about which of these treatment types are relevant. And then late treatment modalities, these are the adults. These are when the growth has unfortunately ceased for the most part, and we have to use things like CPAP, oral appliances, so on and so forth. But having an ENT, and I guess I have to add that here, having a good ENT to help us with things like proper nasal breathing is important. But thinking of this in a hierarchical form is important because this is the time that we have to actually fix people, which is before the problem ever arises. So getting these young kids to the ENTs has always been a frustrating thing for me because it's always the same, which is the insurance doesn't cover it, so we're not going to do it. And as somebody who took the Hippocratic Oath to always take care of our patients because they need to be taken care of, when I hear that from my medical colleagues, I get frustrated. And one of the things that Dr. Pierce is bringing to the table is she's removed herself from the insurance world. So she's able to help kids not because the insurance company may or may not cover something, but because they need it. So looking at this slide, Liz, is there anything that you see in kids that we can do as dentists or see as dentists to make sure that these kids are seeing you at a younger age with things like tonsils and nasal breathing, so on and so forth?
Yeah, I'd say I have to say it's a little bit different now, but when I was at Maine Medical Partners, one of the more common reason we would see kids, it seemed like if we saw a child for snoring, oftentimes it was because the parent would say, our dentist noticed how big the tonsils were and they wanted us to get checked out. Or those at least stick out in my mind. Now, there were the kids who had the recurrent strep. And I always would be like, thank goodness that, and nothing against pediatricians. It's just, sometimes, and I know what it's like, they're just boom, 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 going through the questions, moving along. They look at 1,000 kids' mouths a day and they know that, tonsils can be big. It's just a different, I think, viewpoint that the dentists have that is I always appreciated that when the parents would be like, maybe they're not too big, but we figured we should get it checked out. And then it would drive me crazy when we find out insurance wouldn't approve it because there's no, condition. So anyway, I always appreciate that you all are asking those questions saying, they're not all dentists, but the good ones, the invested ones are saying, is the kid snoring? Man, those are big tonsils. So one thing for everybody to know is that our adenoids, which is tonsil-like tissue in the back of our nose, so you can't touch it, but if you stuck your finger in your nose and went as far back as you could, which you shouldn't be able to do unless you've had your turbinates removed, but you would hit the top of the throat, which is where the adenoids are. And yeah, back there in the upper, kind of behind the soft palate. And typically you can't see it looking in a kid's nose. And you also can't see it usually looking in their mouth because their soft palate just covers it. The adenoids, the tonsils are supposed to be big around age 2, 3, 4, 5. And then they should eventually start shrinking. But if a child doesn't seem to have super big tonsils or has sort of expected for their age, but has just, that mouth breathing, heavy breathing, parents say they snore, they have the mid-face flattening. I mean, we've all seen those kids with the, kind of teeth coming forward young, but still just, they look exhausted. That is where often they have big adenoids. Now, does it mean they need them removed? No. But, and I just saw one of Dr. Jacobson's patients the other day for this, it's worth getting an idea of how big do we think the adenoids are. And we don't always have to put a camera in a kid's nose because, 3-year-olds don't enjoy that. We don't have to get an x-ray. Just looking at them, watching them breathe, having them do a couple tricks, I can get a pretty good idea about their adenoid size. And at least you have a baseline. So, and when you look in their nose, and little kids, sometimes they're full of snot, but if little kids, if you look at their nose, if you don't see a ton of pink, like if it seems like they're moving air somewhat, then you can suspect it's their adenoids. So I would say, I don't think anybody can be, in particular, dentist, dental hygienist, faulted for saying, I don't know, this kid's really mouth breathing. I think there's something going on with their nose because as the ENT, we can say, oh, it's their septum, it's their turbinates, or we think it's their adenoids. So I think having a low threshold, a suspicion and a low threshold to have them see us is so helpful because then the parents, they know if they're invested, they kind of want to know a baseline of, oftentimes it's we're just going to keep an eye on things or do this spray, but they have a good idea. And then I think one thing that I'm sure you probably talk to patients about, but I've had kids who have massive adenoids. They kept watching it. They didn't shrink, and we say, look, these need to come out. Is we'll tell the parents. I mean, by not removing the adenoids, your child's facial structure is going to be different, and it's not a scare tactic, but just emphasize to them that the nose being blocked can literally change how your whole face grows, and that's I think kind of in that yellow side. And then the other thing about septum, no matter how big someone is, people will say all the time, and just like a general statement, just because somebody's septum, which is the dividing line in our nose, if it's crooked, which 75% of adults have some degree of septal deviation. If I see a perfectly straight one that's not been surgically corrected, I'm always surprised. I can't tell you, people come in, they're like, oh, well, somebody told me that, there's no way to fix it or I didn't need to worry about it. Like if you think someone has septal deviation, or they said they've broken a nose a bunch of times at any stage in someone's life, we can do something about that or at least determine how involved it is. So even if someone's 60 and they have a crooked septum and we think that's the issue with their breathing, like it's not too late to see an ENT. If that just sort of as a general statement, I've done septoplasties in people who were 65 years old, and they're like, I can't believe I didn't have this done sooner. I'm breathing better than in my whole life. So
Right.
there's no loss of time, even if something wasn't done earlier. Yes, their sleep may not be great, but at least seeing me, I welcome any of them to come in, because sometimes we can figure out, oh, it's just your allergies, your septum and your turbinates are fine. You just need to, stop letting your cats all sleep on your head, and sometimes it's that.
Yeah, I mean, it's really, and I love all of this, but these patients aren't going to get seen by you unless we direct them in your direction. Patients don't go,
Right.
they don't go to the store and then after they go visit their ENT because they couldn't breathe. It doesn't work like that. They have to be
Right.
directed. And, I think we know the limitations of the primary care model. The primary care physicians they're having to deal with so many things all at once that, they're probably not referring the patients unless they're getting a failing score in their Epworth sleep questionnaire, which has its limitations. But I think there's so much for dentists to do, and I think that's why the ADA published this. We see people twice a year at minimum. If we just look for basic things, we can really change these people's lives. And dentistry, we're so focused on the marginal ridge of number 19 when we do a composite restoration. That's not going to change anybody's life. That makes dentists happy that they can pull off an art inside somebody's mouth. It's important to some degree, but it's not like this. And that's why I'm so passionate about this, in great part because I suffer from a lot of these problems myself. So these are a few books that really help us understand the connection between what we see in the mouth and the rest. The upper left is probably the preeminent book on this topic, which is interesting because it was written by an investigative journalist, for lack of a better phrase. This guy's not a physician. He's not a dentist. He just read the book. I'm not going to tell the story, but it's super interesting. Yeah. And the rest of these are written by dentists with different spins in some form or another. Sleep disorder breathing. I wanted to go over this a little bit just to kind of dovetail to some of the stuff we deal with in a dental practice. Sleep disorder breathing is essentially when the sleep quality or quantity is compromised due to some effect of the breathing. Central sleep apnea is something that you're probably more well versed in, but topic for another day. But we have snoring, upper airway resistance syndrome, and OSA, which is obstructive sleep apnea. UARS seems to, maybe you can shed some light on this. I know what it is because I've taken several continuums, not just courses, but continuums on this topic. Everybody knows what OSA is. OSA is an obstruction down here. So patient is overweight, their tongue isn't released, so it's not spending time at the roof of the mouth. Therefore, it's collapsed back and it blocks the airway. But upper airway resistance syndrome causes a lot of the same problems that obstructive sleep apnea does, but the anatomical and physiological issues are different. It's up here. I had a patient just today who had a scalloped tongue. She had bags under her eyes. She was a Bruxer, and I just asked her a question: how does she sleep? And it's always funny when you ask that question to a patient in a dental chair. They laugh like, "How did you know?" It's like we're some sort of magician. It seems amazing, but when you look at this stuff enough, you can see it from a mile away. But she had a sleep test done, and the sleep physician didn't find anything. So her apneas and hypopneas were relatively normal. And what that means is she's not obstructing down here. Therefore, on a sleep study, she's not showing that she's desaturating. In other words, the oxygen saturation in her blood is not dropping because of an obstruction. But these patients still suffer. And if you look at their polysomnograms, you can see that their sleep architecture is actually drastically compromised. And the rationale is that they have obstructions up here, and they show up different on sleep studies. Is this it doesn't pop up in this world as much. Is this a relatively new diagnosis, and can you shed some light on this and how it shows up in your world?
Yes, I think it will continue to evolve. It wasn't really even a thing that they had a special name for, or, an official name, if you will. I became very interested in sleep medicine back in residency when they were still doing a lot of soft palate tightening. I mean, it's amazing how sleep medicine has evolved in the past 15 years, our understanding of it. And because I remember, yes, the OSA test, there's apnea hypopnea score, and you're mild, moderate, severe. And I can't tell you how many people come back, they get the sleep study, and it says they don't have OSA. And the patient is like, then why do I feel horrible? Why, and you look at them and they don't look rested, and, they also don't need CPAP. And it was this whole category, which I think are way more people. I think our society is so used to just being tired,
Sure.
like not feeling rested, that I agree with you. People come in for ears, all different things, and I'll ask them about their sleep and they'll laugh, kind of like, well, horrible. No one ever asked me that. Or I don't want to, it's fascinating. And then you start just getting people thinking, and they'll be like, oh my gosh, like I don't sleep well. They've just gotten so used to it. Sort of like people who can't breathe through their nose. A lot of them don't know what it's like to breathe through their nose. So they're just like, this is the only nose I've known. I've gotten used to it. I don't think it's that bad. But yes, I think that the UARS is more and more realizing that poor sleep or sleep disordered breathing is a continuum. It's not a one diagnosis and then everybody else doesn't meet the criteria. I almost think of it like the way diabetes, it used to be that, the A1C, like you had to wait till you passed all these criteria and then you had diabetes, versus now there's pre-diabetes, they're watching your A1C, threshold's much younger. It's just our understanding that this is a preventable and still a condition that, even if it's not severe by our metrics, it's very prominent and needs to be addressed. And the good news is that a lot of times, especially if it's somewhat mild, it might just be a medication or an allergen or a lifestyle change. For example, some people have UARS just from drinking wine. But I think awareness of it in our society, and even amongst medical professionals, there's a lot of ground we still need to cover.
Sure.
And I'm convinced at least half, if not more, people suffer from UARS.
Yeah. I mean, we definitely see it. What's interesting with UARS, it's not the overweight male that has hypertension, diabetes, and high cholesterol. That's the OSA patient. That's the severe OSA patient. But there's lots of people that live with mild and moderate OSA that don't fit the prototypical patient. But what's interesting about UARS, it could be a thin, fit female who's 40 and works out every day, eats well, just has an upper airway constriction based upon anatomy.
And one quick thing I'll add is, one fascinating thing is, now that there's so many sleep studies, which some of them are quite good, the polysomnography in the clinic would measure brain waves. So you would get this information about these folks who maybe didn't have OSA but had sleep disordered breathing or UARS. But now insurance, a lot of times, if someone doesn't seem like the obvious OSA, won't cover a lab study. So they're just doing a home one that doesn't necessarily give data to say, look, their sleep is not normal. So it's, you have to have a pretty high suspicion for it. But exactly that, you'll see people, I remember in training at one point, they were like, I don't know, you look fine. You don't look like an OSAer. So, maybe you should, get another pillow.
Right.
Thin person, but
yeah, these are our patients that we see each and every day as dentists. So
yeah,
you can identify these people, have conversations, and then get them to Liz so that they can be properly treated. Again, as dentists, we need to be able to screen for this stuff. There's such this fear that still ruminates through the profession, which is, I can't treat it, I can't diagnose it, therefore I shouldn't know about it. And it's like, no, it's backwards. Your own governing body, the ADA, I wouldn't say governing body, but overarching entity within our profession is saying you actually do need to do this, because it's up to us to be able to do that. Really quickly, I just want to talk about mandibular advancement. I have a whole series of lectures on this, but in a nutshell, proper breathing is the following. Tongue lives at the roof of the mouth, the teeth and lips are closed, there's proper lip closure, and then the air comes down and it makes its way down into the lungs without any sort of obstruction. But sometimes the tongue is too large and there's collapse for one reason or another, the patient's overweight, and then we have an obstruction. That, in essence, is what sleep apnea or obstructive sleep apnea is. There's all kinds of ways, CPAP being the gold standard, where there's positive pressure air that comes down, whether it's coming in through the mouth or the nose. It used to be the mouth, now it's more the nose, because we understand nasal breathing is actually the primary mode of breathing, and that positive pressure air creates the proper space that's there. In dentistry, we can fabricate these mandibular advancement devices, and there's a whole conversation to be had about this, where maybe this isn't the right treatment, maybe the CPAP is better. these are more compliant than CPAP, so on and so forth. But I just wanted to introduce a concept for those that might not understand this, that because the tongue is attached to the mandible and the teeth of the mandible are attached to the mandible, if we have an appliance, an upper and lower appliance that pulls the jaw forward, we can open up the airway. So these are considered gold standard for treating obstructive sleep apnea. They don't work in everybody. It really depends upon where the obstruction in the airway, where it's located. I myself, this doesn't treat me 100%. I wear one with the CPAP because that combination gets me the best sleep that I can find. But the point is, only a dentist can make these. So one of the things that we do in our practice is we actually work with sleep centers, and they refer us patients where the patient is intolerant to the CPAP. So the compliance rate of a CPAP at 5 years is like 47%. So it's pretty low compliance rate of a CPAP, whereas mandibular advancement devices, I think they're at 75 or 80% at 5 years. So, this has its role in the treatment of obstructive sleep apnea, but there's a whole nother mode, which we'll talk about, and that's myofunctional therapy, which is actually getting to the source of the problem itself. So I'm going to skip over this. Myofunctional therapy is essentially it's a multimodal concept that basically says the tongue has a purpose. It's there to function in a certain way. One of the main things is to cause palatal expansion during craniofacial development. So this particular slide calls it tongue posture. Myofunctional therapy is something that I'm learning right now. Dr. Dave Jacobson and his hygienist, I wouldn't even call her a hygienist anymore. She's a myofunctional therapist. They do a lot of this in their practice in Cape Elizabeth. Very excited about what they're bringing to the table. Dr. Jacobson is a certified Vivos provider. And a lot of these tools out there are aiming to try to get the tongue to do what it needs to do. And if the tongue does what it needs to do, it actually doesn't obstruct the airway. So there's a whole role in myofunctional therapy that plays a role here. So I'm going to kind of position here. I just wanted to bring up this topic that I'm starting to think, and I think Dr. Jacobson would agree, that myofunctional therapy is actually the best way to open up the airway. Obviously, there's other modalities out there. But this gets the physiology and the anatomy more aligned for proper breathing. In our practice, we have something, Liz, this is a question for you. So I struggled for a while with sending patients to ENTs and getting nothing. So I felt like I needed to do something. So I came up with this, it's called the nasal breathing triage protocol. I call it a triage protocol because I'm not trying to treat the patients. I tried to find something that was over the counter. This YouTube video here is myself talking. I imported in some videos from Vic Veer. He's an ENT from Britain. Just has some really good patient videos on the world of nasal breathing. My goal here is to have patients leave the office with something to try to prove the point that they can't breathe very well. And if they help improve the health of their nasal breathing, I want them to feel that so that they're more likely to go see the ENT. Mm-hmm. So we have this little bag that we pass out. We have some mute nasal dilators. I've since updated this, and I've actually added some breathe right strips because some patients respond better to breathe right strips. Some patients can't tolerate the mute appliances. These are nasal cones that help to widen the external nasal valve. We have some Flonase, the Neomed sinus rinse. Absolutely love this stuff, like you said, and then some clear xylitol nasal spray. So this is just a protocol to say, look, you look like you struggle breathing, evidenced by the scalloped tongue, evidenced by the bruxism, evidenced by cracked teeth, all of the things that we see inside of a patient's mouth as dentists. And just by looking at them and sometimes doing the Cottle's maneuver, which is a very basic maneuver to assess whether or not they have some sort of obstruction, I'm just trying to prove to them that, look, I'm not an ENT, but I think you should see one, and why don't you get started on healing today? What are your thoughts on this? Because a lot of this you do.
Yeah, I think that's fantastic because first of all, getting people on board with putting stuff in their nose takes some time.
Sure.
They're not just going to be at the store looking for something to put in their nose. But if it comes from a dentist like you who's saying, hey, this is what I think's going on, I want you to see a specialist, but here are some things you can try sort of do your homework ahead of time, you can also let them know, and having done this, you'll have while you're waiting to get in, you'll have some information that'll be useful, make your visit more fruitful. The other thing that is important to tell people with that is that none of those are designed to feel different really the next day. Flonase really takes 4 to 6 weeks for people to notice a difference, but most people, do it for a week. They're like, unless they're in the middle of an allergy flare, they don't notice a huge difference with it because all that swelling, all that congestion takes time. It's a game of millimeters to reduce. So I think setting the stage and saying, hey, these are things you can try. They're all safe. And, specifically they're saying me and saying she'll love to know the update of what you've noticed with these. Like that helps us jump into, sort of the next stage of what's going on. I can't tell you how many people, especially before, people would wait 4, 6, 5 months to get in. And, if they hadn't been trying anything, it's sort of like, oh, if they'd only been doing saline and Flonase during that time, we'd have, we could have used that time more efficiently while they were waiting. It doesn't take that long to get in with me. But I love that idea of it and that they feel like they're somewhat empowered. These are safe things, easy things they can do. Feel free to also tell them like there's a little bit of a learning curve.
Sure.
Like it does, but often most people, once they start doing, especially the xylitol or rinse, they're like, oh, I like this. Like, can I keep doing this? And you're like, yeah, go wild every day of your life. Can't hurt anything.
I made a bet with a friend that the sinus rinse will be as common as a recommendation to brush your teeth twice a day within 15 years.
I like, especially between the rinse and if people can't tolerate the rinse, either the mist, the xylitol, or just saline mist.
Something, yeah.
I'm like telling people like, I wish I had enough money to just have it sent to everybody's mailbox every 3 months in the state of Maine. And so, yes, I love that idea. And going back to what you said about the valve, one thing to also add is our nose is designed, we have cartilage here. If you pinch your nose, you sound different. The cartilage that is here is part of our airflow, but is often and typically a separate process in any of the inflammation. And there are some people who their cartilage, when they breathe in, rather than the tent open, it's supposed to open. It's supposed to be a 17 degree on both sides to open. If it's soft or they've had surgery or trauma, then it can actually suck close. It's called Bernoulli's principle. Like if you suck a straw really hard, you can close it. And so that is why those breathe right strips or the dilators, if they do those and they're like, oh my gosh, that's a whole new world, that's also things that we treat surgically and procedurally in the clinic that may or may not be related to the septum and the turbinate. So just for everybody listening, just to throw that out there, that sometimes there's an even additional cause of nasal obstruction or congestion. And in those folks, they have lots of snoring too, because every night their nose closes. So I love that. I think that's great to keep, encouraging patients to do.
Yeah, it's been great. And it really wows them when a dentist is, caring for something outside the normal realm of dentistry.
Right.
Some other considerations, just understanding where the tongue is. When we take CAT scans, it's amazing. Sometimes the tongue is right here. A lot of times it's sitting down here because it's tethered by a tongue tie. So this tongue tie was the topic of our more recent airway collaborative where Heidi talked about, I believe it was the Marquezon classification on tongue ties. And we went into Dr. Jacobson's operatories and we broke up into groups. And it was amazing to see how tongue-tied I was. And we had an oral surgeon there, Dr. Matt Lawler, who was doing some of the tongue-tie releases. And it's amazing how we can see this stuff if we know what we're looking for, and then we can find the right providers to treat these patients. And tongue tie plays a very critical role in all of this because of the fact that if the tongue doesn't live in the roof of the mouth, it's probably living down here and it's obstructing the airway. So I just wanted to bring that up. Tonsillitis, you talked about this. Mouth breathers are more likely to have them. In the service of time, I'm going to kind of skip over this because many dentists know what to do. But I had a question, dental abscesses being so close to the sinus. So I have a question for you, and it's when we have an abscess that we think might communicate with the sinus, should we consider an alternative antibiotic? So for most odontogenic infections, we're going to use penicillin or amoxicillin. If they're allergic, we'll go to clindamycin or azithromycin. Mm-hmm. But we know that the sinus has more anaerobes. There's beta-lactamase enzymes. So do you tend to prescribe different things for the sinus? And I ask this question because as dentists, I think if we think or suspect that there might be a communication there, are we more likely to go to Augmentin? And Augmentin is expensive for patients that don't have insurance, but what's your take on Augmentin, and is that something we should consider?
Yes, if there's a concern for an odontogenic cause or connection, then I would strongly encourage you to give them Augmentin. Yes, like you said, it's more expensive for some patients and it can cause a little more GI upset. But for the anaerobics and all the broader spectrum coverage, it tends to be just much more effective because the goal is to reduce the inflammation, let that tissue. It's multifactorial, usually the type of bacteria that's causing it. And so it's just to get everybody at once, calm everybody down versus some calm down and then leave some of the, like I hate we have to put someone eventually on Clinda or something when it probably the first time around Augmentin would have been more effective. So our go-to is Augmentin for, an odontogenic source.
Great. All right. The chordotympani nerve and tinnitus, a topic that I like treating TMD. Tinnitus of the ear, and I think long story short, because we could probably talk about this for hours and maybe we have a separate conversation. The chordotympani nerve travels in this area here. So whenever there's a distalization of the mandible, and I actually had a slide here. All right, there's the chordotympani nerve. Here's the condyle of the TMJ. There's the ear canal. If we have some sort of reason that the mandible kicks backwards, whether it's trauma or the patient has a constricted palate, there's all kinds of reasons for the mandible and therefore the condyle, which is connected to the mandible, to actually be distal. We sometimes have inflammation in this retrodiscal space. And tinnitus is often a condition. So a lot of times as dentists, when we hear tinnitus, we're going to refer the patient to the ENT. I think we need to understand that sometimes the answer is actually to get the mandible and the condyle away from this area. Is this a connection that you see often? I've definitely treated patients for this, and their tinnitus goes away. I give them a splint of some kind, and I free up the restriction. But this is something you see?
All the time. And it's, my typical thing is I'll do sort of a tuning fork hearing test on them, make sure they don't have sensory neural hearing loss. That's the most common reason of tinnitus. But if they're young and healthy, we have no concern for hearing loss. I also make sure, there's not fluid behind their eardrum, just anatomically make sure everything, I'm not finding an obvious cause. And I don't have any suspicion for a vestibular schwannoma or something rare. Then almost always our default is, hey, this is, I'm concerned this could be related to your jaw. Have you talked to your dentist? And that's where also we would send people back to their dentist and they would be like, oh, my jaw's fine.
Right.
So, which is super frustrating for patients that are dealing with this invisible but very debilitating, frustrating problem. So yes, we see this very, very frequently. And this is one area that I love the collaboration and interest, that awareness that you have about this, because it can be very frustrating when we're kind of at a dead end for patients.
Yeah. A lot of these people live with this for their entire life. Here we have tongue ties. I know we just talked about it. If you have the patient open as wide as they can, they should be able to touch the tongue to the roof of their mouth. And this is something I learned at our last airway collaborative meeting. I'm like this guy here. So I open wide, my tongue only goes so far. And that might be why I have sleep apnea and why my mandibular advancement device doesn't actually work, because it's actually much more of a tongue tie problem. So that's pretty much it. I wanted to get your take on Inspire. Inspire is the hypoglossal nerve stimulator. We're starting to see this on TV for treatment of sleep apnea. It's so new. I don't know if you have a take on it yet, but it seems like the magical answer for patients with sleep apnea that don't tolerate the CPAP. So I didn't know if you had a take on this.
Yeah, so there's Dr. Rebecca Harvey, my former patient, Dr. Chris Murray in Scarborough, and then I forget who, somebody up in Mid-Coast, they're doing this procedure. It is very beneficial in certain patients. So that's the thing, is it's sort of touted as the end all be all. There's very strict criteria. People have to have a certain BMI. They have to have tried certain things. Their sleep study has to meet all different criteria. And it's a surgery with multiple incision sites. There is a chance that the site can get infected. The device has to be changed out, or new battery every 10 or so years. So far, there's a lot of success with it. But I've seen oftentimes patients don't meet criteria, at least what the FDA or insurance will cover. So it doesn't apply to everybody, but it's a newer option that's safe. But again, it's pretty specific. And also to be, what happened, buddy? To be, you also have to undergo a DICE, a direct inspection of your larynx and airway, asleep in the operating room. So there's just a lot of cost, which, the insurance world controls at the moment.
Sure.
That's
Yes.
pre-operatively, you have to have that done. So many steps, doable, but not everybody A wants to do all that, or B meets the criteria.
Right. Well, thank you, Dr. Pierce. We always try to end before 8 o'clock because many of these conversations could probably go on for hours if we didn't put some sort of cap on it. So this is Dr. Pierce. Her website is lizpiercemd.com. Definitely recommend. Beautiful website, by the way. Very, very well done. It looks like you've launched. It's been updated since the last time I checked. So you're actively improving your brand. Your brand is you're kind of getting outside the world of insurance. So I think your tagline of unrushed appointments is beautiful. Spending an hour with your patients, and I can't wait to be one of those patients to try to get a better sense of my airway and see what you can do to help. So thank you for sharing your knowledge and wisdom here. Definitely want to have you back. But if anybody would like to refer, do you want to speak a little bit about your referral process and how people can get to see you directly? Because I bet there's people in the audience here that could probably benefit from your specialty, but also the patients that they treat.
Absolutely. I'm happy to see anybody. I know people sometimes will call and say, I'm not sure if I have enough of a problem. And I'm like, if someone's mentioned something, or you don't think you're sleeping well, or, you've been allocated to the guest bedroom for your breathing at night, all the, you don't have to have a degree of problem to come in, because it's amazing what we often will find. But yes, I'm happy to, so there's multiple ways it can go right now. Currently, either just literally having patients call the office, which the number's on the website, and they can either leave a voicemail or they'll reach someone. Through my website, there is a way to book online, which patients can either book a 15-minute intro call just to chat with me, or a full-on consult visit. And then referrals can either be from your office, I can see anybody without a referral, so I don't have to have the paperwork in front of me. But if you are asking a patient to give a call, if they want to mention, hey, I saw Dr. Roy, Dr. Jacobson, just that way I have an idea, it helps me put them in context. And the wait time is usually pretty short, so we're able to get people in usually within the next couple days. And then having their paperwork, having their information, even if they call and make their own appointment, then if you guys want to send over their information for me to sort of see what's been done or their images, I'm happy to review all that before I see them. But whether it's your staff, anybody else has a question, I'm not sure if this is the right person, patient has questions, whatever the case may be, please don't hesitate to reach out. Email is also a great way, hello@lizpiercemd.com. I make myself very available because I love talking about this, as you can tell. And I'm so excited about the collaboration. Really, I think this is what Mainers need and deserve, and I'm so happy that it's all happening.
Absolutely. Well, very good. We have, let's see, normally Google tries to kick me off. Does anybody have any questions? If we get cut off, we'll pick up another time, but I'll leave the mic open. It looks like Dr. Libby has raised his hand. Dr. Libby, what do you got?
Hi, yeah. So, Dr. Pierce, I work with Dr. Roy. Just
Hi.
a quick little intro. But I have a kind of question. I may or may not know, but I hadn't heard of it before today because I spoke with a local oral surgeon about a patient I had sent to be evaluated for a tongue tie. He didn't think she had much of one, but he had mentioned a potential procedure, and you may or may not get involved with it, but I'd be curious what your thoughts are, where you can basically do an anterior tongue repositioning is kind of what I got from what he was saying, keeping it from basically reattaching the tongue a little more anterior so it can't fall back into the throat. Is that something you've come across? Does that sound effective for people?
I'm trying to think exactly how that would be. The tongue's a pretty strong muscle, which is I think where the myofunctional comes in. I mean, we sometimes when we release tongue tie, we'll surgically open it so it can't scar back down. I'd have to look into that. I'm trying to think what would be a tongue advancement.
I think it's just a release.
He says not release. He said he would actually It's something where he would have to literally reposition and tighten the tissue so that the tongue can't fall backward. It was not something I'd heard of before.
Yeah. Is it a Dr. Lawler? Is it?
No, it was Rob Walsh from Smoms.
Yeah. I'll have to look into that.
Yeah. All right. Anybody else have
Yeah.
any questions for Dr. Pierce?
Hi, Dr. Pierce. Yes, I have a question. Kind of outside of the airway discussion, but I'm wondering how you would like us to manage, like, if we have a patient, say, that we expose like an oral intro communication when we're doing extraction.
Mhm.
I've heard of, it's typically like in our education, we're taught to call Willock procedure, send it to an oral surgeon, or if you're comfortable doing it in your office. But do you manage those cases on your end ever?
Yeah, so it sort of depends on exactly. So one thing, if someone does have an oral intral, fistula, is oftentimes if we say we got to get the sinus open, get the give that infection another way to drain, which sometimes we can do even in the clinic with balloon to open up the cheek sinus. In terms of closing those, I've done a couple different flaps and different things. I haven't done them yet in my current office, but once I have sort of more of a suite set up, I may be able to. But the short answer is yes, both from sometimes just addressing the sinus, which some people say you have to go, and we'll do it all endoscopically. You have to go to the operating room and make a big, large maxillary enterostomy and do a huge washout. You don't always have to. Sometimes it's, taking this naturally 2 millimeter opening and making it 4, so that rinses and medications can get in there. And then the second thing is if they do have a fistula, it just won't seem to close. I worked with Dr. Rick Crawford. We used to do some combo cases, and I can do them alone now, but some little techniques to kind of close it off. But as you probably know, the site will not heal if that infection is still in there and doesn't have a way to drain out, which is why we'll often, based on scans, based on symptoms, anatomy, everything else, mucoperiosteal thickening, determine if both need to happen or if we can try opening the sinus first, which oftentimes, if done right, allows that fistula to heal.
Great.
Thank you.
Absolutely.
Well, Dr. Pierce, it looks like you have a fan club behind you, so let's go ahead and end this for the night. But thank you again. Thank you for
Always
everybody
fun.
coming in. If anybody would like some CE credits, feel free to message Julie at SacoRiverDentistry.com, and she'll issue those credits on behalf of NECADE for you. So everybody have a good night. Stay warm.
Thanks
We'll
so
see you all
much.
soon. Take care.
Thank you.
Thank you.